After the introduction of onyx with repetitive reflux and push technique that we can inject for a long time, our understanding and also endovascular management of AVMs changed a lot since 1998. And we started to cure the grade 1 and 2 AVMs. And we started to offer at least a treatment possibility for high-grade AVMs. Even such grade 4 AVMs, deep AVMs, this was a blood boy. If we are patient enough, we can offer a cure, although with the higher grade AVMs, we have less chance to offer a cure, but at least with additional treatments, we can provide a cure. This is the post-embolization MR on this patient, 2 years control angiography. So, however, after the Aruba, although we have lots of criticism to Aruba, but still, it gave us the hint that we have to improve our technique. It is not good enough still. And make it usable with increased average quality, not, few good results or few experienced centers, but how about making it more homogeneous? There are several advanced techniques after in the recent years, transarterial flow control with proximal occlusion, which can be done using pressure cooker technique as René does, or injecting with proximal double lumen balloon occlusion, which we use ourselves as well. Multi-plug technique that I'm going to concentrate on in this talk, multiple microcath, simultaneous injection to create a closed system for more effective penetration with less or no venous reflux or venous occlusion towards the end, and transvenous approach, which has been talked already, several different approaches for transvenous. We more and more understand that an effective and safe nidal penetration is all about controlling the flow to, within, and from the nidus to facilitate the intranidal penetration. The transarterial, of course, with lesser early venous migration, that's what we wanted. So there is flow coming, and you catheterize one pedicle, and when you give the material, it can go to the venous side. However, if you control the flow coming from several pedicles, then you may have less material going to the venous part. So it reduces washout flow, especially for smaller AVMs and AVMs with single or limited drainage. Simultaneous multi-plug creates a closed flow system, providing better intranidal penetration. Since washout from other pedicles slows down or interrupted, the technique lessens not only the amount migrating to venous side, but also amount of reflux on the microcatheter, and definitely speeds up the treatment. However, disadvantage is you have to control multicats at the same time, and you have two views by plane, so you have to look at the 4 points at a time. For example, in this particular patient, one pedicle from the ACA and another from the MCA, and then it took us like 19 minutes to finish this AVM, and you see that it took exactly the shape of the nidus, and the venous outlet is taken, but we did not send too much material all the way to the sinus, so we had the flow control and 1 year control on this patient. This patient I treated during the live course, WLNC in 2015, temporal AVM. There was a stricture, venous stricture. That was why we decided to treat this patient. And we didn't want to send too much material to venous side, so we preferred multi-plug technique and put one microcatheter in the, from the posterior circulation and one from the MCA pedicle. And we took the AVM without sending too much material. And this is the end of the treatment, embo closure, and 1 year control on this patient, stable result, no AVM. Another small AVM, 2 microcatheters at a time. And this is the cast that we got. Please compare it with the angiography, and please notice that every piece of it was taken with the flow control. And this is the 1 year control on this patient. Another one. There still 2 microcats. One is Sonic, one is Apollo. That was what it is available. And 2 microcatheter at a time. And this is at the end of the procedure, and 1 year control in the lower row. And this was an interesting case. A physician, the patient is a physician, and having headache and paresthesia of the right leg only. And at that time, Aruba discussion was on, and it was decided that this lady is to be under follow-up, kept under follow-up, but not do any treatment. However, she came with bleeding after 1 year of follow-up. So we went in and embolized. This time, actually, main flow is coming from the pericallosal artery. However, there is some from the posterior circulation through anastomosis. So we put 2 catheters. The posterior did not do much, only to flow control basically, and we were able to finish all. This is the post-operative MRI, and this is the 1 year control on this patient. This lady, actually the 4D, I cannot emphasize the importance of 4D enough. We realized that with the help of the 4D that there is an intranidal aneurysm in addition to the venous outlet, the aneurysmal dilatation of the venous outlet. And in this patient, we found the good working projection using the 4D, and we put 2 microcatheters from the MCA and 1 from the ACA, so 3 microcatheters at a time to control the entire thing. And here is the end result on this patient. And these are the post-op MRI showing the edema around, but otherwise no infarct. This patient had a previous embolization and gamma knife in another city, but bled 3 years after the gamma knife. And this is the angiography when he came to us after the bleeding, having this AVM grade 4. So we have 3 microcats in this patient as well, one in the ECA, one from MCA, and the other one from ACA. In this particular patient, we have leftover, here, this is the end of the treatment. We couldn't push more, and 1 year control is what you see here, so there is still some left over. So we don't know, we are following, and we may plan another session for the remaining. So far, he is stable. I mean, he doesn't have any other event afterwards, but we may plan to do another session, maybe transvenous this time. This lady came with bleeding as well, as it is evident on the MRI. This right frontal AVM having dural supply as well. This time, the first session, we did 2 catheters at a time, catheterization, scepter balloon on one side, and the and this is the first session, after the first session, or the second session. And oops, sorry. There is venous stricture in this particular patient as well. Sorry that, oops, video doesn't, okay. And anyhow, in the second session, we put 1 scepter in the external pedicle and another scepter in the pedicle from the ACA, and using double scepter injection simultaneously. With the flow control, we were able to finish the remaining AVM on this patient. This is the cast. And this is the post-treatment MRI with no harm to the neighboring parenchyma. Another patient, this patient I treated in this WLNC. There is venous structure here. The patient does not have bleeding. Sorry. I'm sorry. No. Well, I cannot make the video play here, but anyhow, the pedicle is having en passage, I mean the artery has en passage pedicles, and it was continuing with normal artery. So I plan to put coils distally in the artery after the en passage segment, the normal segment, so that I will send less material to the normal arterial area, and then put a double lumen balloon scepter here to occlude the AVM through scepter, this time 1 microcatheter, not multi-plug, and okay. This is the stenosis part, and then, okay, so I put distal coils so that I will have flow control, and then place the scepter balloon to the segment where the en passage vessels start, and I inject through here, and was able to finish the entire AVM. However, I did a mistake that I didn't realize the tip of the scepter is stuck at the origin of one of the en passage vessels, was not free probably. That I realized afterwards when I couldn't take the balloon catheter out when I was done. So I couldn't take the catheter out. It was stuck. I didn't realize at the beginning why it happened, because I was only very limited reflux, and with that reflux it should come back very easily. But then when I looked at it afterwards, after the procedure, I realized that it is because the very tip is got into the one of the little pedicles. Anyhow, I left the catheter buried in the groin, put the patient on heparin. The patient woke up fine, and after the next day, after I checked this control CT, no event, I started anti-aggregation and kept the patient on Claxane for another few days till I do the testing regarding the anti-aggregation, and sent the patient home with nothing. I mean, it was clinically totally normal, and she doesn't still have any symptoms or any complaints. I had 6 months MR angiography and MR, but unfortunately I don't have it here. So she is doing fine, and we're going to do in April the 1-year control DSA, and then decide on regarding the anti-aggregation. But in our past experience with non-detachable catheters, we left catheters in 28 patients. And except for one patient with a groin problem, groin infection, we didn't have any ischemic complication due to catheter remaining the catheter within the body. Anyhow, this was the numbers from the old experience with non-detachable catheters, single plug, and this is the detachable catheter era. This includes the multiple catheter technique as well, which is almost half of the patients, and the complete closure rate is increased. But of course, there is more grade 1 and 2s compared with the old series. That might be the reason. Morbid mortality is a bit less, and the bleedings got less, so we think that it improves the technique. And this was a grade 5 AVM, having the patient had a subarachnoid hemorrhage, having this aneurysm. This patient we only embolized with scepter, and a couple of sessions we came up to this point. We're going to continue with this with our embolization and see how far we can go. These are the post-operative, the last MRI on this patient. So the conclusion is, with the impact of advanced arterial intranidal flow control, endovascular treatment can be considered as treatment of choice for grade 1 and 2 AVMs, of course, if there is indication. In order to evaluate the patients better, all patients, whether they have subarachnoid hemorrhage or not, they have to be evaluated using DSA. Cross-sectional imaging is not good enough to say a patient, okay, you don't need any treatment, we can just follow you. This is not a correct clinical practice. The technique may decrease overall bleeding, ischemic complications with lesser venous migration and proximal reflux, making embolization of nidus in high-grade AVMs more effective as well. The amount of liquid embolic is substantially decreased. So we think that multi-plug technique should be considered as well for the treatment of endovascular AVM treatment. Thank you.